Good evening to one and all present here. So today we have the next presentation of basic module and in infectious diseases. So far we have discussed a lot about the different spectrums of antibiotic and antifungal usage and the dosing adjustments in obese patients, the dosing adjustment in renal replacement therapy. But now today we'll be discussing on the most important and the frequently raised query in antibiotics, that is when to escalate and when to de-escalate the antibiotics. So that's the topic for today, and I would like to welcome the speaker for today, Dr. Radhika Krishna Kumar. So she has did her PharmD from Amrita School of Pharmacy, Kochi. She has a total of 4.5 years of experience, currently working as a clinical research associate for about 2 years, leading a team for an ICMR research project at Amrita Institute of Medical Sciences and Research Center, Kochi, focused on implementing antimicrobial stewardship in tertiary care center across India. She is also the team lead of ICMR project in expanding AMSP activities to secondary care centers across the state. She's actively involved in daily hospital antimicrobial stewardship meetings, ensuring appropriateness of antibiotic prescriptions, and providing recommendations for therapy optimization. So she has experience in working as an IED clinical pharmacist under the guidance of IED consultant, Dr. Monalisa Sahu at Yashoda Hospital, Secunderabad for around 1.5 years. Her areas of interest include research, antimicrobial stewardship, and infectious diseases. So it's my honor to welcome Dr. Radhika Krishna Kumar for the presentation. Before moving on to the presentation, I would like to inform a few guidelines for the interest of audience. Ma'am, can you move to the next slide, please? So the participants, they can post their questions in the type box that is right below the screen. So at the end of the session, once the presentation is completed, the question and answers will be discussed. Next slide, please. The feedback can be submitted in the comment box below. There's a comment box called submit your feedback, and it will be available only throughout the live session. And once this live session is completed, it will be disabled. So please post your feedbacks before the session is done. Next slide, please. To claim your certificate, you need to issue the certificate right after the presentation. So it will be valid, it will be issued within the 14 days of attending the event. So you have to log into the website and register for the event to claim your certificate. Next slide, please. The slides are available for download. So there's a PDF icon or download icon that will be available on the screen. So you need to log in, which is mandatory to download the file. Next slide, please. So with that, I would like to welcome ma'am over to you for the presentation. Thank you so much.
Thank you, Dr. Harita, for giving me the wonderful introduction. So as she has rightly described, this is one of the most important topic that we have to cover. So we'll move on to the topic. It's de-escalation and escalation of antibiotics. So disclosure information, I do not have any relevant financial relationship with any commercial interest. So moving on to the learning objectives. First, we'll understand the concept of antibiotic escalation and de-escalation, role of clinical pharmacist in de-escalation, then identify the factors influencing antibiotic escalation and de-escalation. Then we'll explain the step-by-step process of de-escalation and also gain insights into importance of antimicrobial stewardship. So moving on to escalation and de-escalation of antibiotics in clinical practice. So before starting the session, we'll just have a quick question. Like you will go through the question. When would you consider escalating antibiotic treatment for a patient with a suspected bacterial infection? So you can answer the query. When would you consider escalating antibiotic treatment for a patient with a suspected bacterial infection? So you may know the answer for this. So it is not when the patient requested, right? The patient is not the one who is responsible for requesting which antibiotic should be given to them. And we'll not escalate an antibiotic when there is a clear improvement in the symptoms for the patient. And in case of severe allergic reactions also, will not escalate an antibiotic. We can either give antibiotics from a different class or some other antibiotic, but we'll not like it's not appropriate to escalate an antibiotic in case of a severe allergic reaction. So the answer to this question will be when the initial antibiotics are ineffective against the identified pathogen, right? So like whenever we start a therapy, whenever a patient comes with a suspected bacterial infection, we'll give a initial antibiotic choice will be given. So mostly if the patient is not responding to that antibiotic, the initial antibiotic, if the patient is not responding, then that is when you consider escalating the antibiotic. So the answer to the question is option C. And similarly, when would you consider de-escalating an antibiotic? When would you consider de-escalation would be an appropriate choice? So the answer to this question will be option D, when the patient's culture results confirm a bacterial pathogen and the patient is clinically stable, not when the patient develops a new infection, not when the patient's condition deteriorates, or never when a patient tests positive for a viral infection, right? So uh, the first two options are applicable mainly for escalation. If the question was escalation, then we would have gone for A and B. But since the question is de-escalation, it is like when the culture result yield a bacteria and which is found to be susceptible to the like the lower antibiotic, we can definitely go for de-escalation. So this is like a golden thumb rule, like right, we can always do that. So moving on to what is escalation of antibiotics. So it is the practice of increasing either the dose, the spectrum, or the duration of antibiotic when a patient's clinical condition worsens or when the initial antibiotic therapy is found to be ineffective. So there is another like a major thumb rule or a golden rule for prescribing antibiotics. It is like we have to wait for at least 48 to 72 hours before any antibiotic starts working. So in that time in like that in 72 hours we can wait until 72 hours approaches, so we need not be worried if the patient is there is no much improvement. But even after 72 hours, if the patient does not seem to show any signs of clinical improvement, then we can escalation is an ideal choice. We can if the patient is having like on a certain antibiotic, if the patient continues to have fever spikes or there is any other signs of sepsis like hypertension or desaturation, or if the patient is clinically getting worse, then we can go for escalation. So escalation need not be always going to the higher antibiotic. It can also mean increasing this dose of the same antibiotic, like changing the spectrum or then adding a new antibiotic. So factors involved in optimal initial antibiotic therapy. So whenever a patient comes with a suspected bacterial infection, what we have to consider is timely initiation. That is, there should not be any delay in initiating the initial antibiotic. Then we have to check if the route of administration is appropriate. The pathogens, there is an infectious syndrome. When a patient presents with an infection, we the ID physicians and the clinical pharmacists, microbiologists, they have an idea what the patient might be having. Like they will have a general idea of what the condition. If it is UTI, it will have a set of symptoms. So we have to consider initially the pathogen must be covered. So what are the general GNB coverage that can be given? We have to administer that initially. The dose should be correct. The route of administration should be correct. And most importantly, there should be no delay in initiating the initial antibiotic. So this is the optimal initial antibiotic therapy for increased survival. So if a patient comes with severe sepsis, we can definitely go for a broader spectrum antibiotic. And then depending on the patient's clinical symptoms, we can like clinical improvement, we can come down. So when is escalation considered? So these statements are self-explanatory. I don't think that I'll have to give the explanation for this also. Like it is clinical deterioration, lack of response, suspected drug resistance and disease severity. So, clinical deterioration is when the patient's symptoms worsen when a new sign of severe infection emerges, such as septic shock or organ dysfunction. Then there is lack of response. As I have mentioned earlier, on a certain antibiotic, if the patient doesn't seem to respond after 48 to 72 hours, that means the patient uh, either might have a suspected drug resistance or there is a lack of response. So that can warrant a escalation of antibiotics. Then there is disease severity, like for high mortality diseases with high mortality rates, like sepsis with septic shock, we can always go for escalation of antibiotics. So, what are the benefits of escalation? It ensures the patient receives adequate treatment in the face of clinical deterioration, targets resistant pathogens with broader spectrum antibiotics, and can be always life saving in severe infections. So, this is the common escalation strategies. As I've mentioned before, there is only not only adding a new antibiotic, like moving on to the next class of antibiotics is considered to be escalation. It can be also increasing the dose of the current antibiotic and transitioning to a broader spectrum antibiotic with a broader range of activity against various pathogens, and also adding additional antibiotics to cover the resistant organisms or polymicrobial infections. Then, what is de-escalation of antibiotics? So, it is the process like escalation. We have told it is like increasing the dose or increasing the spectra. Similarly, de-escalation is like initially we'll have when a patient comes with severe sepsis and all, we'll have initial broader antibiotic therapy. But on that, uh, it is achieved by avoiding unnecessary antibiotic use that would promote development of resistance. So what we have to always consider is even if there are we are giving high-end antibiotics, always at a point we have to regularly monitor the patient, and we have to check whether there is a window of opportunity to de-escalate the antibiotic. That means resistance should not be developed unnecessarily. So it mainly aims to optimize antibiotic use, minimize the risk of antibiotic resistance, reduce healthcare cost, and lower the potential for adverse effects associated with broader spectrum of antibiotics. So when is de-escalation considered? Just like what we have, the exact opposite of what we have talked about, the escalation, when patient shows signs of clinical improvement. That is when a patient's condition improves significantly, the initial broad spectrum antibiotics have effectively controlled the infection. So in that case, we can go for de-escalation. Then identification of a pathogen. That is in microbiology, like when we get the culture and sensitivity report, if the organism that we are suspecting will initially give a empirical antibiotic therapy, and when the pathogen is found to be pan sensitive, then we need not give the higher end antibiotics like meropenem and all. We can come down to the lower end of antibiotics, like we can switch down from meropenem to Magnex. So that is identification of pathogen. And in case of stable clinical condition, when the patient's clinical status stabilizes and there is no longer a need for aggressive broad spectrum therapy, then we can de-escalate. So what are the benefits of de-escalation? It reduces the risk of antibiotic resistance. It minimizes the potential for antibiotic adverse effects associated with broad spectrum antibiotics. It lowers healthcare costs by using fewer or more targeted antibiotics and promotes antimicrobial stewardship by optimizing antibiotic use. So I think that is clear. Then these are the common de-escalation strategies. That is one of the common de-escalation strategies that you might have heard is switching from IV to oral. If the patient can tolerate oral medicines, then reducing the number of antibiotics used, especially in cases where polymicrobial infections are initially suspected, then switching from broad spectrum to narrow spectrum. So next, coming to the role of clinical pharmacists in de-escalation. So next time, if someone asks what is the role of clinical pharmacists, you can definitely point out these things. And I think 70% of the things that have been written here are part of antimicrobial stewardship program, but I'll just go through it quickly. So, clinical pharmacists are medication experts. They possess in-depth knowledge in various aspects of antibiotics, including their mechanism of action, their PKPD, and they are very well versed in antibiotic spectra and understand their potential side effects and interactions. So, they are, you can call them medication experts. Then, reviewing patient profiles. That is, clinical pharmacists actively participate in patient care rounds, and they are part of the case discussion with the ID team. Then there is monitoring antibiotic regimen. That is, they assess patient's clinical response to therapy and ensure that the patient's antibiotics are effective. They review the laboratory data, such as culture and sensitivity results, and guide in antibiotic decision making. They collaborate with healthcare team. That is what I told when we have a case discussion, we have a meeting with the ID team. So that is the collaboration with the healthcare team. And we also are involved in communicating what the decisions have been raised in the ID meeting to the consultants. Then there is adverse event management. That is to identify and manage adverse events, recommend appropriate interventions or adjustments to therapy. Then educate the patients and their families about importance of appropriate antibiotic use, adherence to prescribed regimens, and potential side effects. That is patient education. Then antimicrobial stewardship. That is play a central role in antimicrobial stewardship program, which aim to optimize antibiotic use and combat antibiotic resistance. Then they also play a major role in documentation and record keeping. That is, they maintain accurate records of antibiotic regimens, patient responses, and any changes made during the de-escalation process. And this documentation is very, it is very critical for the patient care continuity and future reference. And there is continuous learning. So the most important part of this is antimicrobial stewardship. Now, so this is an algorithm for de-escalation decision making at day 3 in a patient who is improving. So we'll just see, like, if a patient on day 3, if the patient is found to be improving, what all can be done. So there are 3 strategies. Like one is to stop the antibiotics. There are 3 decisions to make. One, but the first thing is to check whether we can stop the antibiotic. The next thing, if it is not possible, the next thing to do is de-escalate the antibiotic. And if even de-escalation is not possible, at least to continue or maintain the same antibiotics. That is the decision that as a ID team we have to take. So when can an antibiotic be stopped? So when the clinical risk score does not support the presence of an infection, when you clinically assess a patient, if the patient shows signs of improvement, like there is no presence of active infection in the patient, then also when microbiology cultures do not support the presence of an infection, and any other investigations like your inflammatory markers and your any other lab reports does not suggest the presence of an infection, then we can go with stopping the antibiotic. This is on day 3. So when do we consider de-escalation of antibiotics? So in stopping antibiotics, we told clinical assessment of patient does not support the presence of an infection. But when it comes to, if the patient is, we can't say it is completely the infection is not there, but the patient is gradually improving. So in that case also we can de-escalate antibiotic. And microbiology cultures show positive and show evidence of de-escalation opportunity. That means, as previously discussed, when a culture report shows an organism that is pan-sensitive, that is like a window of opportunity for de-escalation. So that is when you can de-escalate antibiotic. And any other investigations demonstrate that infection is improving, like culture, like any lab parameters, like inflammatory markers are found to be improving. That is when you can de-escalate an antibiotic. And when do you consider maintaining the antibiotic? When you can't stop or de-escalate, then you will have to think about maintaining the antibiotic. That is, clinical assessment of the patient shows improvement, but the microbiology investigations are negative. Like we can't reach a conclusive evidence. So that is, we'll wait for a few days. We'll maintain with the same antibiotic. So this is an algorithm for de-escalation decision making at day 3 in an improving patient. I hope this is clear. And moving on to algorithm for de-escalation decision making at day 3 for a patient who is not improving on the empirical antibiotic therapy. So initially we are giving an empirical antibiotic therapy and the patient is not found to be improving. So there are two things that we can do. One is maintain the antibiotic and the second thing is escalate the antibiotics. So when do we consider maintaining the antibiotic and repeating microbiology investigations is when the clinical assessment of the patients demonstrate that the infection is not improving. Laboratory investigations also shows or any other investigations also shows the patient is not improving, and microbiology investigation shows positive, but it appears to be covered, or the microbiologic investigations appear to be negative. In that case, similar to what we have discussed in de-escalation, but here the patient is not improving. So that case, we'll keep the patient on hold. Like we'll try to maintain with the same antibiotics. In case if anything is happening in between, we have to escalate. So we have to keep the patient on a hold kind of thing, and we have to repeat the microbiologic investigations. And definitely, when we should escalate antibiotics is when the patient clinical assessment shows infection is getting worse, and other investigations also shows the infection is getting worse, and microbiology cultures show positivity and evidence of escalation opportunity. That is when initially we give a narrow spectrum antibiotic, and in case the culture is yielding a CRE, like a carbapenem resistant or any other multi-drug resistant organisms, then we have to go for escalating. Or in case the microbiological investigation is negative, like when we don't have any um, microbiological proof of any infection, but the patient's condition is getting worse, then we have to go with escalation of antibiotics. So this decision has to be taken on day 3. So so this is like a conclusion for that, like clinical bedside approach to de-escalation. Every patient should be given the opportunity for de-escalation, whether it is severe sepsis or any kind of infection. Every patient should be given the opportunity to de-escalate, but it need not be possible always. So next thing to consider is not later than day 3, a full assessment of investigation in and clinical progress should be performed and a positive decision should be captured. So what should be our goal? Our goal should be to stop the antibiotic treatment. If that is not possible, at least to narrow the spectrum of therapy. Even if that is not possible, at least to reduce the number of antibiotics being used. Uh, like there is a redundancy in the therapy or such clinical progress that multiple agents active against the same pathogen are not necessary, right? So we can reduce, like if the patient is on multiple antibiotics covering for the same pathogen, that is not required. So at least we can reduce the number of antibiotics. And if nothing is possible, um, then at least not to de-escalate. Like if there is a lack of microbiology result, lack of clinical improvement, not to de-escalate. So this has to be kept in mind always. So after that, after day 3, every day thereafter, a positive decision to stop, change, or continue the therapy should be made against a specific reason. So at every assessment, our goal is to stop the therapy. Uh, like our goal should be to narrow down it. Always de-escalation should be our preference. Um, unless a positive and persuasive need for that continuation exists. Then moving on to antimicrobial stewardship programs focused on de-escalation. So these are the factors contributing to good AMS in critical care. So all of you might be already knowing all this. Review antimicrobials at 2 to 3 days with clinical progress and microbiological results. De-escalate whenever there is a window of opportunity. Then the role of pharmacists include optimizing dose, identify or review restricted or off guidance antibiotics and prolonged course. Then cessation if no evidence of infection. Short duration where appropriate. And infection control measures, infection input, that is antimicrobial advice. These are the infection inputs from microbiology side. Timely report of microbiologic results. Start only if likely infection, that is always check for clinical assessment, biomarkers, and rapid diagnostics. And only if there is a likely infection, we have to initiate the, like we have to start the antibiotics. Then right antibiotic guidelines, local epidemiology, and host factors. So these are the factors contributing to good antimicrobial stewardship in critical care. So our goal of de-escalation is to determine whether a narrow antibiotic would be more appropriate for each patient. So the de-escalation process, this is the so this is the same thing that we have discussed previously, importance of antimicrobial stewardship team. So how can antimicrobial stewardship be important in de-escalation? So the major thing is optimizing antibiotic use. So you are part of the antimicrobial stewardship team. You might be knowing what is happening inside the team. So, so always the goal is to optimize antibiotic use, prevent antibiotic resistance, reduce healthcare cost. That is from going down, going from high-end antibiotics to a lower-end antibiotics. We are cutting down on the healthcare cost of the patient. Then clinical guidance, interdisciplinary collaboration. There is education and training. Then there is monitoring and auditing. Then data analysis and improvement. So these are the role of antimicrobial stewardship in de-escalation. So these are the factors affecting escalation and de-escalation of antibiotics. So there are majorly 6 factors: the clinical factor, microbiological factors, patient-specific factors, hospital-acquired infections, AMS guidelines, and cost. So in clinical factors, there is clinical response, severity of infection, and patient stability. So these are the when we consider a clinical factor, these are the 3 things. In moving on to microbiological factors, there is always pathogen identification, pathogen susceptibility, and in case of polymicrobial versus monomicrobial infection, how will it affect de-escalation and escalation? Then there is patient-specific factors like comorbidities, then immune status, allergies. So these are the patient-specific factors. Moving on to hospital-acquired infections, in case of multi-drug resistance, how and infection control measures, how will it affect these are the factors affecting escalation and de-escalation. And AMS guidelines include hospital AMSP policies and guidelines, and cost considerations include healthcare cost. These are the factors positively and negatively correlated with antibiotic de-escalation. So positive factors include microbiology result documentation and lower baseline severity, clinical resolution, and culture positivity. So that means initially, if the severity is low, then we can always go for de-escalation. These are like positive correlated with de-escalation, and negative factors include polymicrobial infection. If the patient is having more than one organisms in their culture, it becomes a little tricky. The situation becomes a little difficult to manage. So that is when de-escalation becomes difficult. Then there is multi-drug resistant organism. Then infection associated with a low probability of positive microbiology, inadequate initial antibiotic therapy. So we can always go for broad spectrum antibiotics initially, and the idea is to come down to the narrow part. So, but when initially itself the antibiotic therapy is inadequate, it becomes challenging. The de-escalation becomes challenging in that case. Then there is lack of microbiological documentation. If there is no proper documented culture reports, then it is again a challenge for de-escalation. Then initial appropriate antibiotic that could not be de-escalated. So moving on to the process that are the steps involved in de-escalation. There are 6 steps in de-escalation. First is to evaluate the source, like where was the positive culture obtained from. Next is the infection actually present? Third is to review the culture. That is, check whether if it is the final report or any other pending cultures are to be published. Then review the resistance. What is the organism's susceptibility? Review the antibiotic. What antibiotic the patient is on, or is there a window of is there an opportunity to go any narrower? Assess the patient. Are there any patient-specific factors to consider? So step 1 is evaluating the source. So we have to check for where the positive culture was obtained from. So, sorry. So for positive cultures taken from non-sterile sites, we have to review the type, source and status of the culture. So different hospitals have different like the uh, health record system will be different for different hospitals, but microbiologic culture result for most hospital will be almost the same. Like all these parameters will be the same. So there will be a source. This is like the type of culture where you can check here. Then there will be source, and then there is if an option called status. That is if the culture result is preliminary, or any if it is the final culture result. So this is the step one. We have to evaluate the source. Next is an infection actually present? So, infection is the presence of a pathogenic microorganism that can invade the body part or tissue to cause a symptomatic disease. So, it is like a actual disease, actual microorganism that can cause a disease. But when it comes to colonizer, it is these are commensal organisms that are usually present inside our body, and it can be most of the cases harmless in healthy people, and they can perform vital functions also, like in case of gut bacteria that aid in digestion. They'll be present in non-sterile sites, and they will not be causing much of a infection, so they are called colonizers. And contaminants are the intentional or accidental introduction of microorganisms into a culture when the culture was obtained, or in the microbiology laboratory there is a contamination occurring. So that is the difference between an infection, a colonizer, and a contaminant. So colonizers and contaminants are, if they are positive, then we have to discuss with the clinical uh, team, the ID team. We have to discuss with them whether to consider this as a pathogen, because most of the cases they will be harmless to the people. They'll not be causing an infection. So disease causing organisms are there. Then there is a separate set of organisms called the colonizers or the contaminants. So whether we have to treat should be discussed, like a proper discussion should be made on that. Then we have to review the culture. Is the positive culture complete? We have to ask, is the culture finalized, or any other cultures are pending? Um, and does the infectious syndrome warrant broader therapy than the culture would suggest? That means, like in case of an intra-abdominal infection, an abscess, and the blood culture grows E. coli. So, ideally, for an intra-abdominal infection, we know an anaerobic coverage is recommended. But the culture may not grow. The culture may grow only E. coli. So, whether for that an intra-abdominal abscess, we have to give an additional coverage. So that we have to always consider. Then review resistance. What is the organism's susceptibility profile? So always review the susceptibility profile to determine what antibiotics will be active. If there is an antibiotic you would like to use that isn't listed on the culture, you have to always call the microbiology laboratory for more information. So that is we for like sometimes for UTI and all, maybe fosfomycin can be a treatment of choice, but it will not be tested. So we can call the microbiology and ask what is the susceptibility. If it is found to be susceptible, then we can move on with the treatment. So in case we plan on giving a particular antibiotic, but the susceptibility is not tested, we can always ask the microbiology, call up the microbiology team and ask uh, if there is a chance that that particular antibiotic is susceptible, so then we can give that. Then the step 5 is reviewing the antibiotic. What antibiotic the patient is on, can we go any narrower? So that should always be in our mind. So these are the common de-escalation strategy. Like these are the narrow spectrum antibiotics: penicillin, ampicillin, amoxicillin. These are all the narrow spectrum antibiotics. And moving to the right side, you have the broader spectrum antibiotics like aztreonam. Then you have imipenem, the carbapenems, and then there is piperacillin, tazobactam, linezolid, and all. They are in the broader spectrum antibiotic range. The sixth step is to assess the patient. So we have to always check for any patient specific factors are there to be considered. Like for most of the adult patient, they will have uh, like they will be on polypharmacy. They'll have multiple comorbid conditions, so they'll be taking antibiotic medicines for other conditions also. So we'll always have to check for drug interactions with them. Then there is IV to oral conversion if it is possible. Then there is allergies for certain antibiotics. So all that have to be considered. Any specific patient specific factors have to be considered. So these are the 6 steps. That is evaluate the source. If the infection is actually present, we have to review the culture, review the resistance, review the antibiotic, and assess the patient. So antibiotic de-escalation and escalation flowchart. So this is very simple. When a patient, you can imagine like this: a patient initially comes with an infection. So the priority is to identify the infection and initiate the empiric antibiotic therapy, monitor patient's clinical response, and collect samples for cultures. So there are two options to if the pathogen is identified or not. So if the pathogen is identified, we have to review the culture and sensitivity report and modify the antibiotic therapy accordingly based on the pathogen susceptibility. So always try to go for de-escalation. That is our goal. And if the pathogen is not identified, check for clinical improvement. So clinical improvement also there are two, yes and no. If the patient is having clinical improvement, we can continue the current antibiotic therapy. But if there is no clinical improvement, we can escalate the antibiotic therapy to broader spectrum antibiotic, then again monitor the patient's clinical response and check for clinical improvement. Again, there is two side of that, like yes and no. So if a clinical improvement is there, you can continue that current antibiotic and consider de-escalation at a later point. Like as we have previously discussed, at least 3 days later, we have to check if there is a opportunity for de-escalation. And if there is no clinical improvement, reassess and adjust the antibiotic therapy as needed and monitor the patient's clinical response. So I think this flow chart is pretty easy. I think you can all follow that. Um, yeah. So these are the common antibiotics for escalation. So these are the antibiotics and their potential escalation options. Sorry. And these are the similarly, these are the antibiotics for de-escalation. These are the antibiotics and the potential de-escalation options. So yeah, so next is we can have a question. How can the antimicrobial stewardship team contribute to better antibiotic management? So the answer for that will be by optimizing, the option will be C, by optimizing antibiotic use and guiding de-escalation decisions. So it will not be prescribing antibiotic directly to the patients. It is not by increasing the antibiotic dose or by ignoring culture results and clinical feedback. How the antimicrobial stewardship team is contributing is by optimizing antibiotic use and guiding de-escalation decisions. Next is a true or false questions. De-escalation of antibiotics involves transitioning to narrower spectrum antibiotic when the specific pathogen is identified or patient's clinical condition improves. So, when do we consider de-escalation is what the question is. So, when the specific pathogen is identified or a clinical condition improves. So, obviously, the answer for that is true, right? So, that is when we consider de-escalation. Next is antibiotic escalation is the preferred approach for all types of infections to ensure that most aggressive treatment from the start. So whether it is true or false, antibiotic escalation is the preferred approach for all types of infections. So that is definitely not true. That is false. Then clinical pharmacists play a minimal role in de-escalation of antibiotics, primarily focusing on medication dispensing. So you all know the answer for that is false, because you can always refer back what all are the roles for clinical pharmacists when it comes to de-escalation of antibiotics. So the answer is false. Then seventh question is de-escalation is not necessary when a patient shows clinical improvement on broad spectrum antibiotics. Is it true or false? So the answer is definitely false. So even if there is like if the patient is showing clinical improvement on a broad spectrum antibiotic, it is not like we can there is no need of any de-escalation. It is not the right thing. We still have to consider de-escalation if the patient shows clinical improvement. So these are the situations warranting escalation of antibiotics. These might be the common things that you might encounter, like you might come across on your day-to-day life. So the first one is suspected septic shock. When a patient arrives at the emergency department with high fever, low blood pressure, and altered mental status. So that is like the typical definition for a septic shock. So in that case, always we can warrant escalation of antibiotics. So reason for escalation is in case of severe sepsis or septic shock, broad spectrum antibiotics are immediately initiated to cover a wide range of potential pathogens unless culture results are available. Next is scenario two is lack of clinical improvement. Uh, if a patient with a severe respiratory infection has been on antibiotics for 48 hours, but there is no improvement in oxygenation and the patient is having persistent fever. So in that case also, as we have discussed, we can always go for escalation. That is, if the initial antibiotic therapy is not yielding any positive culture result, escalation may be considered. Then scenario three is positive culture with multi-drug resistant organism. That is, a blood culture reveals presence of a multi-drug resistant organism. Then we have to always go for escalation. So escalation is a more potent and potentially broad spectrum antibiotic is necessary to address resistant organism effectively. Next is next scenario is post-surgical infection with complication. So that is like a patient develops a surgical site infection following an abdominal surgery. The patient initially came for an abdominal surgery, but the patient develops complications like peritonitis or anything. In that case, if the patient is showing signs of peritonitis, including severe abdominal pain or high fever, that case we can always go for escalation of antibiotics. That is, maybe it might be necessary to cover the potential polymicrobial infection. So initially, as I told, the patient came for a abdominal surgery, but when peritonitis or any other complications occur, it can be polymicrobial. So the initial antibiotic therapy may not be sufficient to cover the polymicrobial infection that is occurring in the body. So in that case, we can always go for escalation of antibiotics. Next is the classic scenario when immunocompromised patients with febrile neutropenia. So we have always seen this case, and in immunocompromised patients undergoing chemotherapy for cancer develops febrile neutropenia. So in that case, we can definitely go for escalation. So, because always this is like a case of medical emergency. So, broad spectrum antibiotics are escalated promptly to cover a wide range of potential pathogens. Then, example six is infection in a patient with a non-history of antibiotic resistance. A patient with a non-history of antibiotic resistance. So, the patient is already having multiple recurrent episodes of the infection. So, we know uh, based on the previous culture reports, we know how the patient culture will be yielding. So we can always go for the high-end antibiotic than going with the lower-end antibiotic because we know the history of the patient. So in that case, we can always go for escalation of antibiotics. So these are the examples, like for all the scenarios that we have discussed, what all are the antibiotics to be given are given here. So for septic shock, as we have discussed, meropenem or vancomycin can be given to cover GNB and MRSA. In case of lack of clinical improvement also, we can escalate to broader spectrum antibiotics like BLBLIs or carbapenems to consider to cover potential antibiotic resistant pathogens. Then for positive blood culture with multi-drug resistant organism, escalation to antibiotic with activity against MDR organisms may be necessary. So in that case, antibiotics like colistin, high-end antibiotics like colistin or tigecycline may be used to treat the infections caused by CRE. Then in case of post-surgical infection with complications, we can always go for broad spectrum antibiotics, including imipenem, cilastatin, piperacillin, tazobactam. and vancomycin to cover the potential multi-drug resistant organism. In case of immunocompromised patients, we initially start with usually meropenem, then we escalate it to ceftazidime, avibactam, aztreonam. So that is like warranted. Then infection in a patient with a known history of antibiotic resistance. So patients with a documented history of antibiotic resistance, escalation may involve using antibiotics effective against the resistant strains. So for MRSA infections, antibiotic may be escalated to vancomycin or linezolid. So situations similarly, like just how we discussed about escalation, these are the scenarios where a de-escalation of antibiotics that is warranted. These are the scenarios that you usually deal with in your day-to-day life. So example one is a clinical improvement and pathogen identification. So a patient with a suspected urinary tract infection was initially started on a broad spectrum, and the urine culture uh, results confirm E. coli, and the patient's symptoms have significantly improved. So in that case, we can go for de-escalation of antibiotics. So there is pathogen is identified. It is found to be pan-sensitive, and the patient is having clinical improvement. So that is like a typical scenario where you can always consider de-escalation of antibiotics. Then example two is suspected pneumonia with no pathogen identified. The patient is suspected of having pneumonia, but um, he started on a broad spectrum antibiotic and he is found to be improving. But pathogens are not being identified. In that case, also, since the patient's clinical improvement is seen, you can go for de escalation of antibiotics. Then example three is transitioning from IV to oral therapy. Patient with cellulitis initially receives intravenous broad spectrum antibiotics in the hospital. Patient's condition has improved. Again, the patient is ready for discharge. So this is the most common scenario. Maybe you all might have encountered in your life, like in your daily practice. That is switching from IV to oral therapy, mostly during the time of discharge. Then again, there is suspected ventilator-associated pneumonia with improved clinical status. This is similar to example two. So after 48 hours of treatment, the patient condition has found to be improved. So in that case, we can go for de-escalation and then empirical treatment for meningitis with later identification of pathogen. So a patient with suspected bacterial meningitis is started on a broad spectrum antibiotics. CSF culture confirms the presence of streptococcus. Um, but the patient, once this pathogen is identified and the susceptibility is known, de-escalation to a more targeted antibiotic, like a third generation cephalosporin, may be warranted. So these are the examples. For all the scenarios, what all are the antibiotics to be given are explained here. So these are the few key principles of a new treatment paradigm. Like this is like a key takeaway from what I have been discussing so far. So get effective antibiotic selection right the first time. Base the antimicrobial selection both empiric and targeted on knowledge of local susceptibility pattern. Use broad spectrum antibiotics early. Optimize the antibiotic dose and route of administration. Administer antibiotics for the shortest duration possible. And to adjust or stop antibiotic therapy as early as possible to best target the pathogen and so that antibiotic resistance may not develop. So we are coming to the conclusion. So these are the key takeaways. Responsible antibiotic use is crucial to combat antibiotic resistance, reduce healthcare cost, and improve patient outcomes. Escalation involves initiating or switching to broader spectrum antibiotics when a severe infection is suspected. De-escalation is the process of transitioning to a narrow spectrum antibiotic when the specific pathogen is identified or the patient improves. Clinical pharmacists play a vital role in de-escalation by optimizing antibiotic therapy based on clinical evidence and patient-specific factors. Factors affecting de-escalation and escalation include pathogen identification, patient response, resistance patterns, and antimicrobial stewardship guidelines. And these are the situations warranting de-escalation and escalation in short. So escalation for severe infection, lack of improvement, non-resistance, and de-escalation when the pathogen is identified, patient improves, or a resistance is a concern. So these are the few references that I have used in my presentation. So these are the few upcoming sessions. So first one is the basic module in infectious disease, cycle 2, presentation 10. The topic is antimicrobial dosing in renal and hepatic impairment. Will be taken by Dr. Aisha Sana on May 20th, that is tomorrow from 8 p.m. to 9 p.m. Then there is basic module in critical care medicine, cycle 1, presentation 7. The topic being rapid sequence intubation will be taken by Dr. Harita. That is on May 23rd, Thursday from 6 p.m. to 7 p.m. Then there is basic module in infectious disease again, cycle 2, presentation 13. Topic being antimicrobial loading dose and maintenance dose concepts will be handled by Dr. Saidlu Ganta on May 25th, Saturday, 7. Research and publication presentation 2, topic being basics of evidence-based medicine, part 2, by Dr. Mohammed Rashid. And it will be on Monday, next Monday, May 27th, from 5 p.m. to 6 p.m. And last but not the least, the last basic module in infectious diseases, cycle 2, presentation 14. Topic for that is antibiotic intravenous to oral switch, another very important topic, will be handled by Dr. Arya S. Kumar on May 30th, Thursday, from 5 to 6 p.m. So thank you. That's all. So if there are any questions, you can go ahead.
Thank you so much for the wonderful presentation. I think it was quite useful because you have rightly mentioned all the different strategies for the escalation and de-escalation. So I think it was quite clear. So thank you so much for that. So just a couple of questions
Yeah,
from your side. I know you have worked as a clinical pharmacist. I mean, you also have an experience and you're part of an antibiotic stewardship program as well. So
Yeah.
when we keep recommendations to the physicians on, okay, fine, this antibiotic has to be de-escalated now, or we have to escalate the antibiotics or something like that, there might be some limitations on the acceptance of the same of the recommendations. What do you think is a potential barrier or challenges that you have faced on this successful de-escalation in the clinical practice? So if you could share some of your experience as well, it would be really beneficial.
Yeah, so I think one of the major challenges that during de-escalation, whenever we plan for de-escalation, that can happen is presence of multi-drug resistant organism, right? So whenever in case of a multi-drug resistant organism, it becomes quite challenging. And also when there is a polymicrobial infection, culture yielding more than one pathogen. So in that case, even though we have to check for the patient's clinical improvement, we have to check for any microbiology evidences, we have to check for any other laboratory parameters to check if the patient is clinically and microbiologically improving. In that case only we have to go for a de-escalation. Otherwise it can be a bit challenging, when especially when there is polymicrobial infection. And I think another major challenge is like a fear of treatment failure. So like we there can be fear in the, whenever a consultant is going, so they'll have that fear of what if I de-escalate suddenly, and if the patient has been improving, and what if I de-escalate suddenly and the patient starts worsening. So always that treatment, a fear of treatment failure is, I think, a major challenge. Then there is like a lack of uh, proper documentation, lack of microbiological evidence. If there is, the patient is might be having an infection, but the culture reports might yield no growth. So in that case, I think de-escalation will be a little tricky thing. So I think these are all the major challenges in when you consider de-escalating an antibiotic.
I think that's very right, because especially the one you said at the last, that the patient might be in a strong sepsis, it must be septic
Yeah,
or septic shock, and then finally when we are waiting for the culture to de-escalate, the culture will be
yeah,
yielding negative. So
no growth.
it puts us in a dilemma, like, okay,
Yeah,
what,
dilemma.
because
That will put us in a dilemma. Yeah,
yeah,
right.
yeah. So that's one thing, that's an important thing that you have mentioned there.
Yeah.
So So next question. So in the IP setting, okay, it's quite easy on de-escalating the
Yes.
antibiotics. But what if it's an OP setting? So is there a situation where we have to de-escalate the antibiotics in an outpatient setting? Then what are the strategies to do there? I mean, what are the strategies to follow there?
Yeah, that is like a good question. So, in OP settings also, so the one thing that you can do is always you can educate the provider. That is like the physician. You can always have a training for how to how to give the proper antibiotic, how to there has to be a set of guidelines when we can de-escalate the antibiotics, and also when the patient comes in their OPD, the doctors should have in their according to me in their electronic database, they should have a quick reference guideline, that is like something that is easily accessible and easily we can go through that to de-escalate the antibiotics. So that is a in an OPD setting, that is a important thing according to me. Then you can like now, I think especially during this COVID era, the telemedicine consultation it gained importance, right? So there is online consultation. So patients can always opt for that. So they can always opt for an appointment with the ID consultant, and they can in like most of the patients we know, when after even after discharge they might be continuing on antibiotic, so they can always take lessons from the even if the traveling back to the hospital is difficult, they at the comfort of their home they can take solution for the continuity or what to do next from their treating physician. So I think that would be a in an OPD setting, that would be a great thing. Then we can always include the patient in, like we can in the decision making, we can include the patient. We can tell them then that these are all the things you have been treated for this infection, you were given this particular antibiotic and you have responded. So you can ideally teach them, you can make them aware of like uh, what should be the ideal thing to do. We have to how to continue the antibiotic, we can actually educate them. So I think these are all the few things in an OPD setting we can do.
Thank you. Actually, I think nowadays in the outpatient setting, I mean, I have seen a lot of cases where the physicians they maybe give sparopenem. It's a type of carbapenem drug itself, which can be given orally. So I think there is a lot of irrational use of sparopenem that we are seeing commonly. So
Yes, yes.
is it in your hospital setting? Do you have a stewardship program that is focused on the outpatient patient setting alone, where you monitor these kind of drugs that's being used irrationally, or have you faced such situations where you had to counsel the physicians regarding the use of the same? So any just example that you can recollect?
Yeah, actually, we have a very strong antimicrobial stewardship team in our hospital. And as far as possible, the ID team and the ID clinical pharmacists are um, they are putting a lot of effort to doing bringing that in IP setting. It, as you rightly said, it is uh, easy, like not
Yeah,
easy, like the patient is there, so the
yeah.
treatment is actually okay. But in OP setting, it is a challenging thing, as you told, and we have seen a lot of such antibiotics after all, ferropenem is also a carbapenem, so it
Yeah.
has to be yeah, it has to be given controlled. But we have seen prescriptions going out very frequently from our OPD uh, writing ferropenem. So we are like our clinical pharmacists, our ID team are putting a lot of effort to actually uh, like bring a change into that. But like as you rightly said, that is like a very common practice.
But I think but the situation has changed a lot in this antimicrobial resistance itself, that we have not left with any other options. Because recently,
Yeah.
the
Yes,
patient
yes.
had a
That is
multi-drug
true.
urine infection. He had a very severe pyelonephritis, and then he had to undergo a stenting procedure in order to control the infection. But whenever we send a culture, it's an MDR Klebsiella pneumonia. Actually, even fosfomycin is resistant. There's no drug that we can actually give. And he
Yeah.
has come into the hospital, multiple admissions, and he has received almost all the antibiotics, including meropenem, ceftazine, and everything. And it's
Exactly.
kind of, yeah, it's full resistant. So actually, we have reached a situation where we are not left with any
With
antibiotics
any
now.
antibiotic,
So
right?
yeah, but we can't keep the patient in the hospital for more than 1 or 2 months. Also, we need to discharge the patient at some point. And so,
Yeah.
I mean, in that situation, the physicians are just left with carbapenem, example, just a drug like
Yes,
carbapenem,
yes.
because we have to give something. So I think I think the antimicrobial resistance is a major issue that we're facing right now.
Yes, yes. Antimicrobial resistance is a very major issue. And as you know, there has not been much like new antibiotics are not being discovered also. So,
Yeah, there are no
that is
other,
like a major challenge.
yeah,
Yeah.
no
So
new antibiotics
we
for
are
it. I think
like the
ceftazine is
reserved
the
and
most drug that we are
exactly the reserved antibiotics are also being misused. Like we are put in a position where we have to uh, use the reserved antibiotics quite like um, very much.
Yeah, I
So
think meropenem and
that's
all, we can't call it a reserve antibiotic any longer in
yeah, yeah.
because it's being used routinely. That is not
Yes,
no longer a reserve antibiotic now because once a patient comes in, we just start up like right off with the meropenem itself. But the
correct.
cases turn out to be positive for an NDR infection as well. So I don't know what to do
Yes.
in that situation.
Yeah,
So
so in our hospital, what we do is like when a patient comes from an outside hospital, so it is likely that a patient might be exposed to any other infection. So in that case, we usually start off with meropenem. So I think that is like a hospital policy. We can start off with meropenem. But
yeah,
there are cases when if the patient is even showing improvement and the cultures are yielded to be no growth, meropenem is being continued. Many physicians are doing that, and meropenem is actually very costly. It is
yeah,
like, yeah, the patient, when you consider the economic aspect, it is like the healthcare cost is increasing too much because of
yeah.
meropenem only.
Yeah, I think that's where we need to implement this de-escalation
Yes,
strategy.
yes, yes, yes. Yeah.
Yeah. So just one final question. So now that we know the implementation in the adult setting, so is there anything that's different when we consider the pediatric population here in the de-escalation or escalation from strategies? Is it any different or is it the same?
Yeah, so pediatric population, when you consider the major differences when compared to the adults, in adult population, you will have a lot of comorbid conditions. You will have polypharmacy for the adults. So I think pediatric populations managing will be a bit easy compared to the adult. De-escalation will be a bit more easy compared to the adult population because adult population we have to go through a lot of patient specific factors like what I have discussed in my slides. So there will be a lot of patients will be on a many other like diabetes, hypertension. They'll have a lot of other comorbid conditions for which they'll be taking other medications, and we have to consider the drug interactions. Then there will be allergies. So all those things has to be considered. But in pediatric populations, that will not be much of a case. But then again, there will be an issue with the age and weight-based calculations. We have to modify accordingly. So that is the only thing. Like then there will be difference in the PKPD, like the volume of distribution. Everything will be different for a child and an adult patient. So when it comes to pediatric population, that is the main thing that we have to consider. Like the child, in case of a pediatric patient, we have to always check for the growth, and then we have to check the weight based calculations and also the PKPD of the specific antibiotic that we have given. So I think that is there for the pediatric patients. Otherwise, I think according to me, more challenging will be the adult de-escalation.
Yeah. So I think we have crossed our time limit. So in the interest of time, we'll have to wind up the session. So thank you so much, Dr. Radhika, for the wonderful presentation, and thank you so much for your time. Thanks to all the audience for your patient listening. Please stay tuned for the upcoming sessions. We have many interesting topics that's coming up. So thank you so much once again. And with that, we come to the end. Thank you.
Thank you. Thank you so much. Thank you, Dr. Harita. Thank you.